Okay, so let's talk about pulmonary embolisms and we'll talk about DVTs as well. This is extremely important, very high yield for the shelf and for real life too. We'll start with a case where you have this person with, you know, let's just go through it. They have cancer. That's a risk factor in and of itself for a PE. Um, Additionally, they come in and they're sick. They've got a blood pressure this low. I mean, they're in shock essentially. Cold extremities. These are all extremely bad signs. Someone who is, essentially minutes away from death. So, but the key in the history here is that she's only had 1 hour of worsening shortness of breath, followed by confusion, and they thought maybe she's septic. I mean, and that's certainly a possibility. But the key thing here is the shortness of breath and an oxygen saturation of 84%. Now, in this scenario, that could be ARDS, but again, let's look here closer, and you notice that she has a central venous pressure of 25. And someone who's in sepsis is not going to have an elevated central venous pressure because in sepsis, high output shock, you're actually going to have low central venous pressure and low blood pressure in general. But the point with CVP is that if you have a pulmonary embolism and it causes acute pulmonary hypertension backing up against the right ventricle, that's going to increase the pressure in the right atrium and the right ventricle. And the central venous pressure is a reflection of those pressures, as we'll talk about briefly in a minute as well. So, and again, normal chest x-ray, the EKG gives you nothing helpful. And this is, and key in the history here as well is that she has this swelling in her leg with one leg bigger than the other. So all that put together, this is a pulmonary embolism and an extremely severe one at that. Things in the history are kind of what should always lead you to a PE, and sometimes it'll be obvious where they just were on a long plane flight or they've been immobilized. They'll tell you they've had a recent surgery and they've been laying in bed for 5 days straight. And then as far as the presentation, it can be mild where they just have some shortness of breath and maybe some mild pleuritic chest pain, or they can present like this patient and be, acutely hypotensive and going into obstructive shock. So it's extremely challenging to diagnose a PE, especially on an exam, because it can mimic so many other conditions. And I wanted to give you some clues that, especially in a vague situation where somebody maybe has chest pain and there aren't a lot of obvious things in the history that can lead you to PE, some things that can maybe help you notice this are, kind of like I said a minute ago, that increased central venous pressure. If they ever give you that in the vignette, it's really got to be a PE or a tension pneumothorax or maybe cardiac tamponade. But in this clinical setting, if they have shortness of breath, tamponade is going to require trauma usually or an MI, and that wouldn't fit with this history with a normal EKG. And a tension pneumothorax has only a few things that can cause it on examination. So the point I wanted to make here is that really look closely at every question on the exam if it's a respiratory question, because they're going to try and trick you. And the more vague it is, anytime you have a vague vignette and someone has new onset shortness of breath without a fever, that suggests embolism, PE over like a pneumonia. So just be very suspicious for every question. And then how are we going to manage these people? And that's where it gets even more complex, because we all know about anticoagulation, but this person has hemodynamic collapse. So what should we do for them? Get a D-dimer? Probably not. Take them into the OR and do an intravascular pulmonary angiogram, which is probably no better than the CT pulmonary angiogram, which is the diagnostic test of choice if you have time for it. But in this particular patient who is, again, in hemodynamic collapse, the shelf likes to ask questions like this to remind you that you should start with maintaining the airway and also the breathing and the circulation, and in this case, start oxygen, start IV fluids, and put in 2 large IVs. So make sure you keep that very high up in your brain when you approach any question. Look and see if the patient is stable or not. So once we have stabilized this patient, and well, we're not going to stabilize, but let's just say that we start IVs or whatever, and nothing's really helping, and we continue to notice that this person has blue extremities and blood pressure still extremely low, and I mean they are literally 2 seconds away from death. And the one thing we can do when someone has a PE this severe is we can give TPA or thrombolytics, just like you would give for someone who had an MI and came too late. So that's a last resort. And in this case, we don't have time to do a CT pulmonary angiography. We don't have time to do even a chest x-ray. So the one thing that they recommend you do is a bedside echocardiogram where you ultrasound and you look at the right ventricle. And if they have an acute hemodynamically significant PE like this, the right ventricle should be dilated and straining, and it should be pretty obvious, and the vena cava should be engorged, and the patient should have physical symptoms like JVD and maybe some peripheral swelling as well that suggest right heart failure acutely. So the bedside echo is the test of choice if you need to diagnose this emergently. And only emergency, because otherwise we wouldn't use an echo to diagnose a PE. It's not a very specific test to diagnose this. But in this clinical scenario, someone's dying, you want to give TPA, that's when you do the bedside echo. And just again to tell you that remember that TPA is a treatment for a last resort PE like this. Okay, and remember that heparin, is our usual treatment for someone who's stable. And most people with a pulmonary embolism will be stable, but the heparin really just allows the body to naturally break down the clot with its own tissue, plasminogen and all those things. So it's going to take several days of heparin to really break down the clot. So then we have a scenario where you have a slam dunk pulmonary embolism DVT history, somebody who just had a 24-hour plane flight, and now they come in with shortness of breath. And you're pretty certain that this is someone, they're stable, but it's very likely that they have a pulmonary embolism. So in this case, should we start treatment empirically for the PE with heparin, or should we go ahead and order a CT pulmonary angiogram? And the answer to that would be you need to start heparin. If you know it, if it's a slam dunk, start the heparin before doing the diagnostic testing. But again, after you start the heparin, that's when you want to go and do the CTPA and make sure that this is actually a pulmonary embolism. And if it's not, then you want to stop the heparin. In the case where you have a patient who has a contraindication or to heparin or anticoagulation because they recently had a brain bleed or are bleeding in general, then we can't start the empiric heparin. And in this case, the correct name would be to order the CTPA, but ultimately, if they can't be anticoagulated, what we're going to have to do for them is to give them an inferior vena cava filter, which is a really bad option. They're only really supposed to be a temporary bridge until you can actually anticoagulate somebody, because these can allow small clots to build up in the filter and ultimately can possibly obstruct the entire inferior vena cava. So just be aware that that is a last resort for somebody who can't be anticoagulated. And here's another example of a pretty vague presentation for PE where you have somebody who comes in with 3 days of this, pleuritic chest pain on her left side, and also she's got these leg symptoms, and they've been present for 5 days. So the leg symptoms actually preceded the shortness of breath and chest pain. So, and this is interesting because she feels fine, and she doesn't have any shortness of breath, and she hurt her leg. She remembers actually injuring the leg playing roller hockey, right? But you look at the leg and it's swollen and it's bruising, and what we have to ask ourselves is a DVT likely, or in this case, is a pulmonary embolism likely? And the answer to that is probably not. Even if she's having some pleuritic chest pain, in this clinical case, it's unlikely that it's caused by a PE. So given our low clinical suspicion, this is a case where it's reasonable to order a D-dimer. So the utility of our D-dimer is that it has strong negative predictive value. So basically, we use what's called the Wells criteria, and we've been applying that throughout this lecture already. And essentially, you ask yourself, given the risk factors in the history, is this somebody who has high-risk factors like malignancy, they've been immobile, just had surgery? If you have risk factors like that, you don't need to order a D-dimer. You have a high suspicion for PE, and the D-dimer is not going to tell you anything. It's just going to delay treatment. But in a patient like the one we just saw, PE is probably not the highest diagnosis on our differential. We think something else is probably more likely, and in this case, it's reasonable to do D-dimer, and if it's positive, that would lead us to ultimately go and order a CT pulmonary angiography or a compression ultrasound to look at the leg and see if there's a clot. All right. So how do we work up the PE? Like we said, so it comes back positive, that previous patient, and that's when we're going to order the CTPA. Like I just said, it's also called a spiral CT, so be aware of that. But you should also be aware that if the clinical vignette tells you that the patient has a creatinine elevation to 2, or they have renal insufficiency, chronic kidney disease, that's a situation where you wouldn't necessarily want to give them a contrast-enhanced imaging study. And the ventilation perfusion scan would be the preferred option because it doesn't use contrast. Okay. So in another case here, this is in particular important because, you know, I go over this in the pleural effusion lecture also, but they're going to try and trick you. They're going to give you somebody who has a mild pulmonary embolism with an infarction in the lung, and they're going to try and make you think that it's a pneumonia or another lung process. But my point here is that somebody who comes in with hemoptysis and pleuritic chest pain and new onset shortness of breath, you might think that that sounds like a pneumonia, but in the absence of fever, I wouldn't say so. I'd say it sounds more like a PE, because a PE can cause hemoptysis in about 30% of cases. And their vital signs here are pretty benign, and you don't really have much on exam, but you notice that it's dull to percussion, suggesting there's an effusion. And I don't think that we usually think that people with PEs have effusions, but about 40% of people actually do. So chest x-ray confirms the effusion, and we want to know what the most likely cause is. And in this case, like we've been talking about, the most likely cause is probably a lung infarction. And what you're dealing with here is a small pulmonary embolism that occludes a distal branch causing, or a distal artery causing a small amount of infarction, leading to that pleuritic chest pain due to irritation of the pleura and hemoptysis from bleeding around, you know, where that lung tissue is infarcted. And it's that same infarcted tissue that can go down and build the effusion at the base of the lung. And you should also be aware that this can be an exudative effusion. So again, they're going to try and trick you and make you think this is a pneumonia. So read carefully, because they will try and trick you. Now we go on to leg pain here, and I'm just giving you a classic case of a DVT here. The sign that you should be most aware of that should suggest this to you is when one leg is bigger than the other in the presence of symptoms like recent surgery or the things we've already talked about in the Wells criteria. And what should we do to evaluate it? CTPA is what we use to diagnose a pulmonary embolism. And in this case, again, we do not want to do a D-dimer because we are highly suspicious that there's a clot here. So the best answer would be to do a compression ultrasound with Doppler. Okay, so we proceed to ultrasound. No need to do a D-dimer like we talked about. And like I said, if she had some shortness of breath, the CTPA would be equally appropriate here. And the risk factors are the same, so we don't need to monkey around with this anymore. I think we get it. So some 2 points I want to make clear to you is that the most common location for a DVT is not in the calf muscle or into the deep veins in the lower leg. It's actually in the iliofemoral veins, or the veins proximal to your knee. So be aware of that. That's a great test question. And there's a syndrome called phlegmasia ceruleus dolens, which is really dramatic. You have this big enough deep venous thrombosis in the proximal iliac veins that it actually goes on to occlude either both iliac veins or the inferior vena cava, and causes literally both legs to turn blue. It can cause gangrene, and it's a surgical emergency. They have to go in there and break the clot up. But just be aware of that diagnosis. It's something that on the shelf they may give you and you may have to diagnose. So we see a DVT on the ultrasound, and in the absence of PE symptoms, or even if we had PE symptoms, what is the best treatment here? And I think we all know the answer would be to initiate anticoagulation and to initiate it with heparin, most likely. Okay, and eventually bridge to warfarin after a couple of days. So just a few facts about anticoagulation that you should be aware of. Lovenox, which is low molecular weight heparin, is just as good as unfractionated heparin, and those can bridge you over to warfarin. They may not put either one of those on there and ask you to pick one of the new oral anticoagulants. So I don't think that that'll be a challenge for anybody. But one thing to keep in mind is that if someone has a temporary risk factor, like a medicine they were taking, like birth control or recent trauma or surgery, then that's someone who only needs anticoagulation for a temporary period, and that would be 3 months. Whereas somebody with a thrombophilic disorder or a chronic risk factor for anticoagulation should be anticoagulated indefinitely. So you have that same patient who you started the unfractionated heparin on for her DVT, and 6 days later she comes back and she's got what looks to be like a new DVT in her right arm and in her right leg, which is the opposite leg that she initially had the symptoms in. And you draw labs and you find that her platelet count is low to 90,000. So what condition do we think this is? And is it HIT1 or HIT2? She's thrombocytopenic. She's been put on heparin, so we can assume it's one of those two. The key factor here is to look at the duration of time it took to get the symptoms, which is 6 days. But more importantly, to notice that she has new deep venous thromboses, which suggests hypercoagulability, and that is going to be heparin-induced thrombocytopenia type 2. Be aware of this condition because it is frequently tested. It will be on your test. And type 1 is completely benign. It's a mild platelet drop. And the key to know is that HIT1 happens within 2 days of starting heparin or Lovenox, low molecular weight heparin, so be aware of that too. And for type 1, you don't do anything. It's fine, and you can continue giving them heparin. Type 2 is, like we're talking about, more serious, and it takes at least 4 days to develop because this is an antibody-driven disorder, so you have to give the body enough time to form antibodies, and that's why it takes at least 4 days. The exception to that 4 to 5 day rule would be somebody who has previously had heparin before and was able to generate antibodies. Then you re-expose them, and that might take 1 or 2 days for them to regenerate. Those memory B cells can pump out antibodies faster in that case. So if somebody does have HIT type 2, the treatment initially, number 1, is to stop heparin or Lovenox. Just stop them. That's number 1 thing. And you need to start an alternative drug to anticoagulate them, which would be any one of these 3 drugs, which are all factor Xa inhibitors. You do not give them a platelet transfusion because this is a consumptive process, and if you give more platelets, the antibodies in there are going to just chew up the platelets and actually make the thrombophilic nature of this disorder worse, cause more clotting. And you can't give them warfarin because due to the low platelets, you can predispose them to warfarin necrosis. And I hope that they don't put this on your shelf, but one thing that you can use to confirm the diagnosis, if you need to, would be to order a 14 carbon labeled serotonin release assay. I wanted to put that in there so you're aware of it. That's something I would try to remember right before test day. It's pretty irrelevant for real life, but it might be on your shelf because that's the kind of thing that gets put on a shelf. So just a word about prophylaxis. Anybody in the hospital who really has trouble getting out of bed or patients with comorbid cancer or other illnesses, you want to give them low-dose heparin or low-dose low molecular weight heparin to prophylax against the development of these DVT. You can also choose to use a sequential compression device if the vignette gives a history of bleeding or a history of heparin-induced thrombocytopenia. And if somebody develops a PE in spite of our prophylaxis, that's fine. We're just going to increase the dose to a therapeutic level of heparin because that's a much higher dose than the prophylaxis dose. And one more thing just to hammer in for you, somebody who gets a recurrent DVT despite anticoagulation, these are people that need the inferior vena cava filter. Fat emboli, last thing I think we're going to talk about here, you got to have it in your brain. It's going to be on the test. It was on mine. It's an extremely commonly tested topic. Maybe on your test twice. I don't know. The key in the history is going to be a femur fracture, and they're going to have sudden onset, confusion, hypoxia, shortness of breath. 1 to 3 days after they broke their femur. And then finally, they're going to get these little red petechiae all over their trunk and head, and that's going to confirm your diagnosis. This is a clinical diagnosis, and given everything right there, you've already confirmed the diagnosis. And you should know that it's also caused by the fat globules jumping out of the bone into the blood. And if you see an increased CRP, that would support your diagnosis, that just being the vignette.